Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Thank you, Maren. It's so good to be with you at the end of a very busy day. A lot of great stuff has happened, and we hope that you have been able to cash in on that. So this is going to be a unique panel in a lot of ways, but what I want to kind of emphasize is that this is our chance to hear from what state leaders are thinking about. We have nothing pre-scripted, no prepared remarks. It's going to be free-flowing, and we're going to actually just kind of hear from them on their minds. So with that, first I'm going to invite to the stage Kevin Mcavee, who is our moderator today. And Kevin, thank you for filling in at the last minute. He's about 2 minutes ago that he was going to be doing this. And just so that we make sure that everybody's on the same page, we are going to invite 4 of our favorite state leaders. And we have many favorite state leaders, but these are 4 of our favorites. And we are just going to hear what's on their minds. Maybe we'll come up with some specific topics we could ask them about. Today, this is our chance. So with that, I'm going to bring them to the stage and let you start grilling them on what they think is important. So we have first Rachel from CHIA, Massachusetts. Nikole Helvey is from Florida. Nikole is not able to use video right now, and we're going to have her be audio only. We have Anna English from CIVHC in Colorado. And we have Dr. Joe Thompson from ACHI in Arkansas. And I'm going to step backstage so that the screen works better and let.
Absolutely. Well, thank you all, Anna, Dr. Joe, Ray, Nikole, for joining us today. I came running as soon as I heard I would have the opportunity to speak with each of you and pose a couple of questions that I think have been pervasive throughout the conference so far, and I think will carry us forward through the remaining days. And so the first question I'll put out there for each of you, and while I think you're thinking of responses, and I'd encourage the audience to start submitting questions that you'd like this group to answer. I'd like to start with some of my reflections over the past 18 months. I think as we've headed through the public health emergency, it has demonstrated both the power and importance of health data, but the power and importance of health data not being situated in silos and alone. Like data so often becomes usable, actionable information once it's linked and brought to policymakers, audiences who can actually use it and respond to it. And so I'd love to hear your thoughts on like whether this resonates with you and how you, with your individual health data organizations and your data resources under your stewardship, have been linking data to derive new information to inform action and response. And I'd love to start with Dr. Joe, and then Anna and Ray and Nikole, if that order works for you all.
Well, thanks, Kevin, and thanks to my co-presenters and the NATO for having us here at the end of the last day to start, really looking forward and dreaming big. I think for all of us, probably the last 18 to 20 months have not been the world that we planned to operate in 2 years ago. And at least for us in Arkansas, our relationship, because of our APCD's authorization vesting in state agencies, the insurance department, allowed us to offer some surge capacity and actually some linkage opportunity with the health department as they really ran up against some challenges early on in the epidemic. We actually got a direct feed of COVID positive cases, and also from their data, individuals that were hospitalized on ventilators in intensive care units or unfortunately died early on. And we linked that data to our all-payer claims data to see what were the risk factors that those individuals had, what were the comorbid conditions that led to increased likelihood of bad outcomes. So we were early out of the gate within the first couple of months of being able to give the clinical community relative risks of bad outcomes associated with COVID. And from there, we went to providing geographic level information on rates of COVID infection. Now we're trying to push forward rates of COVID vaccination. I think the capacity and kind of the analytic horsepower that some of the APCDs have harnessed became an emergency response unit for the health departments in many ways.
Very.
Yeah, so CIVHC we've been working on a number of initiatives over the last number of years, of bringing in alternative payment models, looking at what some of those programs are, a lot of work on drug rebates, and it's taken us a few years to really make that information fairly useful. But it's not just the claims data. We geocoded the information. A lot of the social determinants of health, we're now just starting to provide some level of indicators, quality measures that ties in, that's based on not only what we have in the APCD, but also with social determinants of health. So that's a big step, but it takes a lot of work. And the problem is we have to plan ahead. We're having now, there's a lot of reinvigorated discussions with how can we merge together with the HIE data, the real-time transactions. So there's now a lot of, how can we share our indexes, our patient index, our provider index, to start bringing those together? The problem is that it takes time and it's not necessarily benefiting some of the here and now, but it is definitely building that momentum. And the other thing is also the state registries, the cancer registries. So some of that is requiring regulatory changes that now there's a lot of effort going on to make those changes now. So for us, it's really about how is the momentum being built, and how are we able to do it at a faster pace.
Excellent. And Ray, I know of so much work you've done in Massachusetts previously, linking and kind of serving as the backbone for some analyses, such as opioid analytics.
Yes, linking is increasingly becoming a major part of what we're using the all-payer claims database for. There's really just so much data you can bring under one roof, and then at that point you're boiling the ocean. And so it's really about providing kind of the goodness of our claims data assets to other organizations that are doing other things with public health or really other social service delivery types of activities. So a major one that we do is the Department of Public Health in Massachusetts pulls together now over 25 databases from across state government, things like corrections records, E911 calls, service indicator flags from different health and human services programs. And it was originally all this was pulled together to give researchers better insights into the opioid crisis, but it's now been expanded to cover several other major public health topics. And so that's a separate agency from CHIA, that's the Mass Department of Public Health, but it's an example of they get sort of a full copy of the APCD, and then they use it as the kind of the backbone of this public health data warehouse. So the data gets used again and again. I guess that's another major point, is that embracing use of the data by other state actors is really important for us. And then linking, which, that particular project is at its heart a linking project.
Yeah, and I think Nikole, are you going to be joining us on stage? Do we have you in the studio? Nikole, are you with us? Okay, so I'm actually, while Nikole will resolving some of the technical issues there, I do have just a follow-up question before moving on to another question from the audience. So often linking data faces technical barriers, legal data sharing barriers, and also just relationship barriers with data agencies that might not be used to kind of sharing information, even working together on a daily basis. Do any of you have any tips, advice, lessons learned from your experiences successfully linking data that you'd want to share with our NATO membership?
Well, I'll be glad to start, Kevin. We had started off with personally identifiable information, and we're linking to our Health Information Exchange, and actually 5 years ago had this vision of this was really going to work well. Then the Anthem security breach happened, and personal identifiable information became radioactive. And so we had to actually create a hashing process through which we could get a high fidelity of matching, but the hash had to happen outside of our purview at our direction in the plan. So we've gone through this, much like, trying to follow Ray's example and with Anna's experience. We now have the birth records and the death records and the cancer registry linked to the all payer claims database. In a little bit, we can talk about the medical marijuana experiment that we have going, which is another unique linkage process. But I think, direct to your question, finding the pathway that you can gain comfort of the data suppliers, but still make progress. As you make progress, comfort levels grow and the use cases and value proposition become broader. But finding that starting point is really a tough nut when you're dealing with different data sources and you're starting to talk about, every linkage makes the data more powerful, more valuable, and more dangerous.
Yeah, and I think for us is in dealing with all of the different organizations, whether even the differences amongst the state agencies, the issues are different. And, you have to peel back the onion with each, and I think my whole team hates that phrase or loves the phrase because I use it too much, but, you just really have to peel back the onion and you have to have those conversations. And a lot of it is just the relationships and understanding what is potentially trying to find out what the right solution. And we have some solutions in place that allows us to get the vital statistics and get access to the vital statistics, but it's a jerry rig and it's a Band-Aid. And we realize that in some cases it's truly the regulatory and the statutory changes to really make it operate very common sense, because in some cases it's really a backwards process, but that's what we have to do.
Ray, any thoughts there?
I guess there's two things I would add is that we've been the beneficiary, I guess, of it's always good to have a major driver. So, I won't say, never let a crisis go to waste, but I do think that when something important is happening and you have the tools that can, be an important part of the answer, I think that's when you have to shine, and that's when you have to, hope that you're called on to step up. So the opioid crisis was, our APCD has been around for a long time, but the opioid crisis was a major step forward in terms of its use and utility and kind of the, there's a lot of added emphasis on it. So I think using kind of business drivers, if you will, to make sure that your data is serving a really critical need for your state is one way to move things forward. The other thing I'd point to is we're very lucky in Massachusetts to have a consensus around the importance of measuring our healthcare system. It's a huge source of income in the state. So it's not like we dislike our healthcare system. We love it. We're proud of it. It gives us great healthcare, huge income industry for the state, but it's a big expense item in every single budget, every individual budget, every family budget, every business budget, every government budget. So it starts with just measuring it so we can make better decisions. And that seems to be non-controversial, and that goes a long way to helping us get the data we need to get.
That's really interesting. And Dr. Joe, something you mentioned, the more you link data, the more powerful it is, potentially informative it is, and dangerous it is. And I think there's both like danger for de-identification as well as like danger as in terms of like who it's going to tick off. Because like Ray, I think from a conversation we've had previously, like we can talk about healthcare spending and by all measures, probably most in this room, when we think about healthcare spending growing by 5% per year or more, we know that it's an unsustainable problem. But for every dollar that goes into the healthcare system, that's also like $1 of someone's salary. And like, so there are always going to be two sides of a coin. Like, how do you grapple with kind of the sometimes difficult stakeholder dynamics for those who might really applaud certain data and information coming out, and those who might be opposed or take issue with it? And I don't know if maybe does anyone want to start, Anna?
Sure. one of the things that I think is that we've worked really, really, really hard on is that we really define, our compliance framework, and we try to be, not too far into the center, because then we mitigate the value, and we really try, but be right inside the frame. And we do that for everybody. We don't, we try to be as objective. We service all stakeholders as long as we are operating within that compliance framework. We try to treat everybody the same. So whether you're a hospital, a payer, even the pharmacy, though we don't work very much, if at all, with the pharmacy organizations, but we would treat them the same, physician groups, the employers, et cetera. And for us, it's, antitrust, HIPAA, high tech, and for the better of Colorado in this case. And as long as we're being consistent, and we don't try to give preference to one or the other, I think that's the biggest challenge. And we do a lot of public reporting. We try very much so to be equal in the amount of public reporting we do, whether it's hospitals or payers. And we're doing more activity now that shows some of the variation with some of the payers that has created some of the, a little bit of feedback, shall we say, to Civic, whereas, they don't mind if we're doing a lot with the providers and the hospitals in particular. But, that's some of the challenges to make sure that we're as balanced as possible. And that's hard to do. It's really, really hard to do. And being really clear of what's our framework, what's our compliance, what's the parameters and the policies that we try to operate around as it relates to our reporting, whether public or non-public. I think that's the challenge, the biggest challenge for us.
Yeah, I would add, obviously, the objectivity that Anna's talking about is paramount. If you're seen as favoring one perspective over another, that is your fastest way down the toilet drain from a political and from a trust perspective. Having said that, if you stay in the safe zone, then the value proposition of the data becomes really limited. As you mentioned, at least in our state, probably 1 out of every $5 that change hands every day is in the healthcare system. And it's a black box for most people, even most highly educated, fully engaged, leading business people. It's a black box. So I think finding ways to translate data into information to answer real problems starts having people ask the question, what other question could we ask of the data that we're having a problem with? And you can't always be answering only a problem for a hospital or a health plan, but if you have in your mind a rotation, or in your strategy, a rotational basis by which you're looking for those important problems to answer from different sectors, then I think you start broadening the comfort level and hopefully building the trust to move farther and faster.
Yeah, I think the repeated references to trust are exactly right. And that's got to be earned day in and day out. It's by doing all the hard work of data cleaning and, kind of data resubmissions when it doesn't look right, picking the right topics, right? Having that sort of fair and balanced approach that Dr. Joe was talking about. We try to serve, we're not trying to push any particular viewpoint. We want to make sure that there's as many facts on the table as possible so that all the different stakeholders can make their arguments in a fact-based way. And that is one of the things I would point to, is that I've never seen the data end an argument. It merely makes the argument more evidence-based, but then there's always that next level. Because if you say, why is spending going up? And you look and it turns out that outpatient spending is going up slightly faster than other categories. Well, why is that? So you dig into it, and whatever you find at each level, there will always be more that you need to know. And so I try to reassure the stakeholders that more knowledge will never just conclusively come down on one side or the other of the debate. It just tends to make a more evidence-based debate. And so people shouldn't be afraid of more information coming out for these discussions we have to have around healthcare. It's too important.
And just to add one thing to that, I think one of the greatest successes on some of the policy initiatives is when we have the multitude, the different stakeholder groups coming to us, as well as legislators. It's the same underlying data, but they may want it presented just a slightly way. It is allowing, as you said, Ray, that conversation to occur. And even though they may have their viewpoint of how they want the data to be looked at and or used utilized, they're all working off the same underlying data. And it's very fortunate, we believe, when they can utilize CIVHC and the Colorado APCD to do that. But yeah, I fully agree with that.
Mm-hmm.
Kevin, I would, if I can just insert, you also have to have a thick skin and a strong backbone to do the right thing sometimes. Just to share, and this is a recent experience, not related to our APCD, but related to my center as the Center for Health Improvement committed to transparency. CMS requires nursing homes to report weekly the number of their residents that have been infected and the rate of vaccinations, and the number of their employees that are infected and the rate of vaccinations. And it's buried somewhere deep on the CMS website that nobody can possibly find it. So we drew it out and put it in a very easy, consumer-friendly, publicly facing way, because we thought if somebody's having to decide where they put their mother today in a nursing home, level of vaccination rates would be an important and transparent piece of information to know. Needless to say, when we showed some nursing homes that had 16% vaccination rates of their employees, it generated a lot of white heat. The legislature, Bureau of Legislative Research, is looking at my budget. They want to know what my personal expense account is, of which I don't have one. So I think you've got to recognize that sometimes doing the right thing in the moment of truth is going to generate some negative energy. And hopefully, if you've gotten that trust as an honest broker and as a source of information, you can sail through those choppy waters.
I think that's it's fascinating to hear, and trust, being an honest broker, putting out data and information that individuals, policymakers, regulators, consumer advocates can use. I think all are components of developing this evidence-based conversation, whether it's for policy making, program design, and system reform, or otherwise. And I think that one of the reasons I was so excited to talk to each of you today is ACHI and CIVHC and CHIA, I think, quite often aren't just kind of responsive to what has happened, but also kind of, I've seen each of your organizations kind of look ahead to what is happening. And I'd love to hear a little bit more about how your agencies are addressing local priorities, issues that are coming up day to day now. Dr. Thompson, congratulations on the recent grant, and I'd love to hear more about the medical marijuana initiative. Anna, I know you're doing so much with social determinants of health, and Ray with bringing so much of so many of the data assets together to inform some state reforms that are on the horizon. I'd love to hear more about each of your efforts in those areas. Dr. Joe.
Well, let me tell a story a little bit, and we should play the Gilligan's Island theme in the background just for appropriate strategic planning, because this was not, we planned it, but it wasn't necessarily strategic. Arkansas passed in 2016 a constitutional act that legalized medical marijuana. Not the first in the nation, won't be the last in the nation, although 46 states now have some type of legalized marijuana use. That was an initiated act passed by the people, but I would say not supported by the legislature. In fact, strongly not supported by the legislature. And so when it came to writing the rules and regulations for medical marijuana implementation, my team, Craig Wilson, my policy director, we said, let's not let a crisis go unused. And so we actually passed legislation ultimately that allowed us to have, if an individual was qualified for medical marijuana under the 18 conditions that they apply to the health department for, we have a flag in our APCD of whether they are qualified. And now we've extended that through the Alcohol Beverage Control Commission, as Anna was talking about, rules, regulations, statutory strategies, to where we're now going to have what the person actually purchased, the amount, the strain, the frequency, and we kind of said, okay, this is kind of unique and nobody else probably has it. So we put I went to the NIH Commons, I said, has NIH ever funded an APCD for research grade work? And I would say, you know, they have twice, mostly with the Massachusetts APCD, not with many others, but we put a pretty good grant together and found out that at the end of the year, they had a little extra money. So they funded us, and we're actually going to get to do this study of the purchase of medical marijuana. And we're fairly agnostic. I don't know if it's going to reduce opioid use in the prescription, high dose opioid users, or whether it's going to have an increased, you know, incidence of mental health conditions in younger individuals. Both are postulated for medical marijuana, but we're going to be able to look at the 70,000 individuals that are consuming now on a population basis, and look forward to sharing that at a future NATO conference as we get this under our belt.
That's great.
And I think for the data community, this is actually a pretty important achievement with the high-grade NIH funding streams to actually start to recognize there's value in understanding how different systems, granted it's administrative data, a lot of the claims data are not as detailed as you would like, but it can answer some important policy and system level information questions that have gone unanswered to date.
Fascinating. Congratulations for the award there.
We'll see how it comes out. That may be another one. We have poked a tiger that we don't know if he's inside or outside of the cage.
We'll have to have you back next year and provide the epilogue. Anna?
Yeah, you know, so Colorado, needless to say, uses, you know, we've had it around for a few years and we see some of the utilization, but some of the stuff that's been going on, you know, within Colorado is, you know, and we look to what some of the other states have been doing. But one in particular is, you know, we've had the surprise billing out for a number of years and we're really trying to find out, okay, so now, you know, we're producing the reports that's the basis for, you know, the non-par or the surprise billing, and we're waiting to say, okay, what's the outcome of it? So sometimes there's just that delay, and so we're hoping that we'll be able to see what the benefits are and have been, you know. But there's a lot of activity in the state regarding drugs and drug prices and drug utilization. So Colorado just put in a prescription drug affordability review board bill, a statute that went into place, and a lot of excitement, though it's going to be a few years, you know, before we start seeing the outcome of that. But the APCD collects a certain amount of that information, and then we've got around 4 additional bits of information that's coming from the payers now straight to CIVHC in order to go ahead and fulfill some of the needs and the data needs for that particular group. You know, I think one of the challenges is that it takes time. You know, so when these policies are first talked about and then they're put into place, and then by the time the regulations are then put in, and then you start collecting the data, and then decisions can be made. And I think another really prime example of that is the Primary Care Collaborative, and that is an awesome initiative within Colorado. But that, you know, getting the reporting, making the decisions on how to collect the information, it's a multi-stakeholder effort, and we're really pleased on being able to provide the data. But they're just now getting to the point, and rightly so, to start looking at, you know, what should those benchmarks be and what should those thresholds be. And so I think the frustration is that you've got to make the decisions to move forward, utilize the data, and then start putting in place those policies that will help drive the change. It just takes time.
And Ray, every time the legislature is in session and a healthcare bill is passed, I just know it's like an over/under. I'm like, is CHIA going to be asked to do more than 3 things or fewer than 3 things in the bill? How have you been able to kind of grapple with that on a year-to-year basis already with a pretty big scope of work?
Well, it's a great point, and it follows up on Anna's excellent comments that I'd say a real priority for CHIA is trying to, what I would describe it as shortening the time to analytics cycle, which is the APCD is such a powerful tool, but the lead times can be quite long, and even outside of, you know, for other data assets. And so, for instance, we're now we've started, we knew that our governor and legislature were interested in measuring and creating incentives around primary care and behavioral health spending. rather than waiting for the statute to pass to collect the data, we actually started as part of our annual aggregate data collection. We have all the health plans in Massachusetts reporting to us their primary care and behavioral health spending. So we now have that data and that legislative discussion was derailed by the pandemic. So they are now re-engaging in those discussions. And instead of having no baseline, we actually have very rich data. So we always try to be very keyed into what we can start in on early so that we can get a head start. So that's one point. Secondly, we've just finished a really large project working with IBM Watson Health to convert our APCD from what is really just a vast repository of EDI codes on some levels and turn it into a true data warehouse. Up until now, in order to access our APCD or really to use its power, you needed very specialized people that would, create a query. That query would get QA'd. There'd get, data would get extracted. That data extract would get QA'd. There was a long time from somebody having an idea to the data actually being provisioned to an analyst in an analytically ready fashion. And so what we've done is tried to convert the rawness of our APCD into something that's more like a data warehouse with a Tableau front end. So a lot of work's gone into grouping it, enhancing it, adding lots of things so that, an NDC code is all you see on a pharmacy claim, but you can link that to, to the drug name, to the manufacturer, to the drug class, to lots of other information. So we've tried to pull all that into our APCD and put a nice visual front end on it to reduce this time to analytics challenge. We want our analysts to be able to sit down and kind of explore questions at the APCD rather than sort of needing to wait for something to become a big issue that prompts us to create an analytically ready cut of the APCD that we then provision to our analysts. So getting the data in front of our analysts on an exploratory way is very important, we believe, to shortening those cycles. So anyway, time to analytics is a really important consideration.
Yeah, I love that theme, and maybe we could stay on that for a little bit longer of reducing analytic lead time. Ray, I remembered way back when I was working, and hi to everyone at CHIA who's watching right now.
Exactly, we miss
50
you.
folks. I remember like blood, sweat, and tears for 2 years, and we got a data point, and it was from data that was like 6 years old, and we were so happy, but it really wasn't very useful. And I think that a lot as APCD agencies and health data agencies mature, we really start to kind of grapple with and think about how to build the human capacity and capabilities as well as the technical capacity and capabilities to shrink that analytic lead time. Dr. Joe and Anna, does this really resonate with you, and how have you kind of grappled with this age-old problem?
So I'll jump in real quick, but this is one of our strategic objectives. Is we have historically been reactive. A request comes to us, we go ahead and go through the process. We help to define, what questions they're trying to answer, and we're either supplying them with the data or performing the analytics. Whatever and whether it's using an interactive reports or even if it's a public report that we do. But so we're trying to move from reactive to proactive. We have got an unbelievable, similar to all of you, we've got an unbelievable set of analysts. They're highly experienced. They know what's in the data. They're in the data all the time. And so we've really gone through a process of ensuring, similar to what Ray was describing, of where they've got a certain amount of their time allocated to just being innovative, to just looking at the data, being more proactive, finding ways that we can pull information out. And we did a number of analysis that were ended up utilized for some of the COVID committees for how they were going to distribute the vaccines. We're utilizing reports that we did. Hey, there's a need, so let's go ahead and put forward this information. That let's not wait for someone to ask us for it. So that's a big strategic shift. It's and even though it may seem very minor, but for us, it's a big step. As to how we manage our staff and how we manage our resources and how we think about how we're supposed to be helping the industry as a whole.
Kevin, I would just, and your question sounds overly simplistic to me. The process of getting the data in, process so that it can be placed into an analytic, set, and then finding the question to answer, going through the it is heavy lifting for the most part. I would agree with Ray's strategy of trying to build it less into a technical database and more into a functional database. I think is an important step. The other thing we've done, and it has served us well, at least in our attempts to be less stressed by being reactive, is we've actually got a flag. When we get a question now, we can shift into what we call a rapid response mode that brings both the data managers and the analysts together so that we find the shortest path through the process. And that really is we kind of define what can we answer in 72 hours. I mean, if a new legislative question hits the front door, can we answer it in 72 hours with a rapid response effort? We've still got other projects going on, but you can't treat those unique opportunities like other projects, or you just will drive yourself, over the brink.
Agree. So one question that we did receive from the audience, Imelda, I would like to know what initiatives states have that have affected the nursing home population since they suffered the biggest impact during COVID. And I would actually like to expand that just a little bit more, if you don't have anything specific around nursing homes, to a question about how your health data agency and organization might have pivoted and put the front burner issues up front as we were working through the public health emergency and had to shift priorities. I don't know if there's anyone who'd want to take that first, really thinking about your priorities over the past year and how those have changed over time.
Well, I know that for CHIA, I mean, we're not the Department of Public Health, and we're not the Executive Office of Health and Human Services. So we were one step kind of removed from the frontline response to the pandemic, but it still completely, changed our world. We dramatically increased. Well, on the one hand, we waived a lot of the mandates around data submission from our data submitters because the payers and providers were under a lot of stress. But we actually also accelerated our data collection. So there were certain things that we used to collect only quarterly that we started to collect monthly. And we started to build our data sets, for instance, our case mix data of hospital discharges. And that's really where the action was. We used to only build it on an annual basis. Well, that obviously wasn't good enough for COVID. So we actually turned into monthly releases of case mix and monthly benchmark analyses of our case mix data. So we transformed ourselves quite a bit in response to it, even though we weren't, as I said, the Department of Public Health. But I would say, I think there's a longer discussion, but there's an interesting issue around, I think one thing the pandemic showed is that we live in a vast health data ecosystem, and we haven't really been thinking about it systematically. And not only is it underfunded, but no matter how good CHIA gets at what CHIA does, the whole system depends on hospitals and nursing homes and labs and local departments of public health and lots of different data standards. And I think no state was prepared for what happened over the last 18 months. And I hope that we can do a good job of trying to, should it ever happen again, that we're more integrated and coherent in our response, because it was a scramble and a lot of great work happened, but it was a scramble. So hopefully the one takeaway I would like to have is that when we can catch our breath, that we do some systems analysis and think about how we could really do some things a lot better next time, not just do the same thing harder.
Kevin, I would just pick up, I think we all know this, but just to make sure it's on the table, the exposure of our inability to deal with disparities and the differential impact of COVID on low-income communities and communities of color. I think we barely have health data that scrapes the surface to show those things. And I think that really is to raise kind of system assessment and Monday morning quarterback, figuring out how we incorporate race and ethnicity in a solid way, and income in a solid way, and transportation in a solid way, so that you can understand some of the variation in healthcare utilization outcomes. I think those gaps were really highlighted. I will say on the flip side, telemedicine exploded, and we were able to show how telemedicine substituted for in-person care, and where it really provided care where no other care was available for folks with ongoing chronic illness in the face of the pandemic. So two different sides of the same nickel, telemedicine and opportunity for acceleration, but disparity, understanding disparities, and whether that's racial, economic, rural. I mean, we just our U.S. healthcare system is not prepared to even start to scratch that surface.
Yeah, and I have to, agree. I mean, we update our database every 2 months, and so what we did is we developed for telehealth, because again, that was one of the hot topics and whatnot, and so we started updating with each update of our database, whereas normally our public reporting, we will update periodically, normally on an annual basis. But so this was the first time that we had our online interactive reports that we were updating with each and every one of our data refreshes. So because again, telehealth, it was much more meaningful to have it more real time, shall we say. And so that was a learning curve for us and understanding as to what some of the issues were surrounding that. And I agree with you, Joe, the disparities, it really had caused us to move a bit further along because our data that we received is really challenging that we're getting from the payers, and we're working to say, okay, how can we go ahead and improve the quality of what we're receiving on race and ethnicity, and then it also created an opportunity to really bring in the census data and overlay census data to see if we can really gauge as to how good our data is from a quality, but also supplement and overlay those social determinants, the census data.
I'd like to actually build on that. So I think that we did, like Monday morning quarterback, Dr. Joe, as you mentioned, like our health system did not perform, especially on the IT and data side, as we would have wanted it to through the past 18 months. It really revealed significant deficiencies in the linking capabilities nationally, in the versatility and responsiveness of the systems we have invested $30 billion in. I'm particularly thinking about EHRs through high tech. And it also was a reminder of the ongoing inequities and disparities we're seeing in our populations every single day. And Anna, you mentioned like in working with the payers to improve race and ethnicity data completeness and collection. And my question, I guess, to all of you, as you really kind of think about what's next in your role of your organizations within your states, within your regions, is what is the role, or what can be the role of health data organizations to facilitate better data collection to inform our understanding of issues like health inequities in our environment? Oh, right, you're on mute.
I'll jump in first because sometimes it's at least for CHIA, we have pretty broad statutory authority and high level of trust with our stakeholders, and we try not to we're very cautious, I think, in kind of adding new mandates. So sometimes it's as simple as we decide to go after additional information. But in the case of race and ethnicity, this is actually one where work is underway in Massachusetts to get at these data elements. But when you think about it, CHIA, we have, a perspective and it's important and so on, but really the state Medicaid program, that race and ethnicity data really has to be usable for, people beyond CHIA who's just measuring the system, but for the state Medicaid program and for private commercial insurers, it really has to be usable by them for their business purposes, because we want them to be able to offer programs and things to actually improve care. And so instead of just CHIA deciding how it will be done, there's actually a multi-stakeholder task force that's underway in Massachusetts, and they're coming close to final recommendations, and then those will be adopted. They will be imposed by regulation. That data will be collected. But it's important that it actually follow a multi-stakeholder process, because that data has much utility really across the system. And I think that if we just tried to jam through our view of it, we would actually regret that and probably have to revisit the issue.
Yeah, and one of the other things too is that we're dealing with Colorado, is that also the state Medicaid is looking at modifying how they're collecting race and ethnicity, but the federal government is too. And we also have to, since we're collecting the data from the payers and the insurers, if they are not getting that level of information, it doesn't serve any purpose for us to mandate the collection of that data, because they don't have a manner of which to supply it to us. So right now, we've expanded some of our race and ethnicity data based on what we know is available. And then we're waiting for the state and the federal government to go ahead and determine what the what the parameters are going to be or the structure is going to be going forward, and then we'll adopt it. It's a fine line to put things in place that the insurers and the payers really don't have a ways to be able to give you good data.
Kevin, I would just add, and it sounds like CIVHC is on a similar path. I think in lieu of a direct source of race and ethnicity, using an indirect overlay of census tract or other sources of information, it doesn't allow the management of individual, clinical situations, but it does allow the assessment of kind of policy issues that need to be addressed, for which you have no other source of information to examine. And I do think the COVID-19 disparity experience will accelerate the need for this type of information. And there'll be a window where, as Anna says, it's not yet going to be available, but we're going to need to find a proxy for it that is at least better than nothing.
That's where we're going first also, is to get our data submitters to both case mix and claims data to geocoded at the census block group level. So we have very granular, we can link it to very granular census information, which is a good proxy.
Absolutely, and so that's really interesting, and I think this ties a little bit to our health equity conversation. But like most states and APCDs also have an inherent limitation, and I just said it. Like it's the state borders quite often when we are often grappling with regional issues. How do you how do we resolve that? Are you kind of working, or have you thought about working with other states to kind of bridge data gaps, really address regional issues, or does there need to be a national or federal solution? And then I actually want to go to a federal question to close us up today.
I guess as a state, I've never, I tend to have the state-centric focus, and I mean, we're aware of, and we tend to, we measure residents that sort of come in from neighboring states, so on and so forth. I do know that we share data pretty extensively with the other New England states. And so I think, I don't know enough to have an opinion about whether a federal approach is the right way, or if its states should be, with perhaps, the federal government leading the way on standards, states sharing with each other as needed. But certainly taking a view beyond just the state borders is important.
And I have to say, benchmarking is extremely valuable. And we've worked with a lot of different states, and also looking at, our neighbors, but just that benchmarking, because when you're only looking at yourself, you're only looking at the variation amongst the different regions within your state. But it's pretty eye-opening when you're able to compare it to these other states. And we've done a number of initiatives that really have highlighted where there are significant opportunities for Colorado to make improvements.
Kevin, just to give you a burning question that I have no ability to answer because of the lack of a regional strategy. So Arkansas was the only southern state to expand Medicaid in 2014. Louisiana has joined, but the others remain somewhat recalcitrant. I would love to know what Mississippi's health utilization and statistics look like compared to Arkansas. There is no difference on the Arkansas side of the Mississippi River and the Mississippi side of the Mississippi River on any socio-demographic or economic or educational or economic opportunities, other than the availability of insurance for low-income Arkansans and the lack thereof for Mississippi. I think it's that type of really important policy question that you could get energy around regional responses. I will caution against a federal solution. What would be the death nail for APCDs is to have a federal solution that puts so much lag time in the process that it ended up being like CDC data sets that come out 3 years after the fact. I think most of us would immediately lose a lot of our support because it would just be another data collection process, but not necessarily a value proposition.
Going where I'm going. So as we think about the role of state data collection versus this very real and live federal conversation around is there another method to most efficiently collect and use data? Is there a happy middle ground where perhaps states collect data by a common standard and share a certain amount of it back up with a national or federal data source? Where is the middle ground to derive efficiencies and also make sure we're collecting data by a common standard?
Well, I mean, I can speak into the common data layout, so CIVHC fully supports getting towards, in Colorado in general, getting towards the common data layout. And we have one section, of the common data layout, which is what we're working with the state now to put and bring that into part of our DSG, our data submission guide. And so, the more that we can all get closer to the common data layout, it will allow us greater opportunities with the ERISA work and the Department of Labor of being able to bring in some of that, non-state, data such as ERISA to kind of help build out our databases. So I'm fully in support, but every state, we have very specific nuances that is tied to the state regulation, not only for the APCDs, but in how what the data may mean or what is the priority for each individual state. And I think that's what's so critical that could be lost, if it were to all be mandated at the federal level.
Absolutely. I think you've got to go with a federated approach, because this is not our only, we have other data collection activities from health plans in addition to getting claims data from them. We get lots of aggregate reports from them, and that relationship isn't going to go away. And we're just in a better position to understand the local healthcare economy and the participants in it using federal standards. I think federal standards make a whole lot of sense, but there's, I think, just other data collection and other activities that happen with the state and with hospitals, health plans, nursing homes. And that's where I guess I part company with the Supreme Court on the Gobet decision. I think states have sovereign, right and responsibility to measure their healthcare sectors. They're simply too important not to measure. And so, I think it's something that we just have to do.
So I'll join my colleagues and add a little bit of flavor. We actually, Craig wrote into our legislative statute that any self-insured company that receives state funds must report. So we actually have 3 or 4 of our largest 5 self-insured companies, the state employees, public school employees, any state university that self-insures must report, the state police must report. So there is a little bit of a policy strategy to get a window into that self-insured space, even despite the Supreme Court decision. And I would also echo the value to states of a federated model with full federal participation is the ERISA plans that are totally private in my situation that I don't have line of sight on. Although one large one has said they would voluntarily submit. And I guess I would just, in the final caution, it's important that as we talk about a federal standard or the common data layout, that common data layout is not fully baked and completed, and it needs to be informed by states that have a lot of experience on when data elements don't actually work the way that you think they're going to work. Sometimes we have a double-barreled question inside of a single data element, and it would be better to split those apart and say, are you eligible for this, yes or no? And then if yes, what is it? Not just say, have a variable say no or unknown, because then you end up not knowing what to do with that data element.
Yeah, absolutely. I couldn't agree more. And Anna, I know on the self-insured question, CIVHC has done a lot of engagement with self-insured employers. Have you had success there in bringing them to, and what has actually made them contribute, if so?
Well, we can talk a lot about our lessons learned and what tactics we've tried and aren't quite as successful. But, first off, we do receive all of the non-ERISA. So those that are the public entities and so on are required to go ahead and submit. And then we've worked with a lot of the purchasing alliances, and there's a big movement within Colorado on these purchasing alliance, and they've actually been discussed quite a bit nationally as well. But we've worked with partnership with them. And so any of them that are participating, these ERISA plans that are participating with these alliances are required to submit and be a part of the APCD. So we're trying different tactics. And we're also looking at some particular legislation that, for example, or regulation that other states have done to help mitigate some of the difficulty where employers want to go ahead and submit their data, but because of some of the administrative hurdles that that some of the payers or the TPAs have in place, it's been very difficult to get them to submit. So we're working on how we may be able to help support some of that through some regulatory changes that will have those TPAs that if they're submitting these non-ERISA to the APCDs, they have to allow, or again, we're working through the language, but that they would need to allow these employers, these ERISA-based employers that want to submit, they need to allow them to submit. A lot more detail behind it, but at a high level, that's pretty much what we're different activities we're trying.
That's really exciting, and I know that we're closing in on time here. So I have one last lightning round question for this panel of our late breaking session, which is I couldn't quite understand what late breaking session was in a year like ours. So much has changed over the past 12 months and seems to change on a weekly basis. But to the extent you can predict what the year ahead holds, like what is your main year ahead priority, whether it's kind of the top priority or kind of new priority on your list? I'd love to go around. I don't know if there's a volunteer to take that one first.
Well, I'll say, we have policy priorities, and they are really what we're all about. But I will say we've just finished 3 years of development on our new APCD platform. So for us, a major priority for this year is the first year of operations of this platform and really using it to shorten that time to analytics so that we can get our analysts looking at questions as quickly as possible.
I have to say for us, the social determinants of health and doing some of the integration with our state HIEs on the clinical data is really, really important for us.
I would echo Anna's too, social determinants, HIE. I think we will also be a unique partner with the health department to track COVID positive patients on the long haul aspect, because I don't think there's another population-based strategy to actually know what COVID is actually going to do to our population in terms of healthcare, diagnoses, and utilization. Excellent.
I can't thank you guys enough for joining us today. This has been a freewheeling, wide-ranging conversation, but certainly an incredibly informative and insightful one. I'll pass it back to Norm, but thank you all for taking the time to join us at NADO today.
Thank you.
Thank you, Kevin. Thank you, everyone, for your participation. We just have a few announcements. I hate the word announcements because it sounds like somebody's going to make you, torture you or something. But I have a few things that people need to know. One is that we do have winners for today's drawing in the top 20 category. We've got Dagmar Velez, who's won the $50 Amazon gift card for being in the top 20 and then winning that drawing. And then Donald Poe won in the overall category. Also coming up next, we have an opportunity for you to meet with our Spotlight Session experts. So if you haven't had a chance yet to visit the Spotlight Sessions, you should do that. But most importantly, coming up at the half hour, those experts will be available for interactive discussion. I know they've had lots of people talking with them. A very interesting opportunity to meet with them and interact with them. Finally, tomorrow morning, we have two fun things that you want to miss right off the bat. Don't miss 11 o'clock Eastern, virtual coffee shop. Nothing formal, nothing planned. We've got 4 coffee shops open for you to come and just talk about whatever's on your mind, just like you would at any sort of a coffee shop. And we have a 5th one that has no host. So show up, be the host if you're the first one there, or just enjoy that one. Just have a good time there. Right after virtual coffee shop at 11:30 Eastern, we have our federal panel. So this was a lot of fun to have our state leaders. Tomorrow, it's the Fed's turn. So we've got leaders from ONC, from CMS, and from HHS ready, or from ARC at HHS, ready to talk to each other and to entertain your questions. So load up those questions, get those ready. Kevin and Craig will be back tomorrow with the federal leadership panel as well. So thank you, everyone. It's been a fabulous day. Yesterday was a fabulous day. All of the video recordings of all the sessions from yesterday are functional. Most of the ones are from today we'll have them all up within about an hour or two. If there's anything that you missed, please go back and watch it. Feel free to take a look at that and let your friends know as well. So with that, I'm going to go ahead and conclude my remarks. I think we're ready to head off to meet some of those fabulous spotlight sessions. And again, thank you so much to the panel and for Kevin for jumping into moderating at the last minute. This has turned out to be a fabulous opportunity. Thank you, everyone.